we've just seen. Though dramatized, is an episode of factitious disorder imposed on self, defined by the DSM, and involves feigning or inducing physical or psychological symptoms for no observable external gain. The patient often behaves in a secretive, deceptive manner to facilitate this facade of illness. The purpose of this behavior is not fully understood, but it is known that the sick role is of significant importance. It's a relatively rare disorder with a prevalence of around 3%. What wasn't mentioned in what you just saw is that the doctor was one of many hospitals Charlie visited. She would often spend nights in the waiting room and eat in the hospital cafeteria. She would frequently feign her illnesses during off hours to avoid raising too much suspicion. She exploited the HIPAA protections that prevented her records from being viewed, and in an attempt to conceal her identity, would hop from hospital to hospital, telling self-aggrandizing stories of her illness and procure extensive, unnecessary testing. These tests eventually took a real toll on her life. She eventually left the hospital system, and her current whereabouts remain unknown.
Excuse me, sir. Excuse me.
Yes? What is it, young inquisitive boy?
Well, I was just wondering, why might an old innocent woman like Charlie induce or feign symptoms like this on herself?
That's a good question. We are still trying to understand this. First, it's important to differentiate between other similar diagnoses. One article outlined a spectrum with hysteria on one end, an old somatic diagnosis typically associated with young, wealthy females, and malingering on the other end, which was more common among young, poor men who sought compensation or tried to avoid active military duty. In the middle of this spectrum is factitious disorder, which neatly fits between the two, where the behavior is often unconscious and the patient does not consciously reinforce it. Individuals with factitious disorder may also feel they deserve punishment, express anger toward physicians, attempt to master past childhood illness traumas, or covet interactions with high-status health professionals. Additionally, their behavior might reflect suicidal wishes.
Wow, it really sounds like there's a lot of differential diagnoses when it comes to factitious disorder.
Exactly right. Munchausen syndrome was originally considered a diagnosis by Asher in 1951, but wasn't included in the DSM until DSM-3, and Munchausen by proxy was also included as a variant, where someone imposed these feigned symptoms onto another individual, often a child, elderly person, or someone with a developmental disability. However, in DSM-5, Munchausen and Munchausen by proxy were redefined as factitious disorder and factitious disorder imposed on another, respectively.
It seems like there would be a lot of work to feign these symptoms. How exactly do they induce these symptoms on themselves?
Another fantastic question from this interesting young boy. Patients seem to inoculate themselves with household products like hairspray to induce persistent lip swelling. Eating an excessive amount of licorice can cause adrenal irregularities. A fever can be feigned by consuming hot beverages, warm wax, or wet cotton in the ears. Wounds are often infected with human or animal fecal matter. Asthma can be faked by tampering with a pulse oximeter using clear tape. Metal might be inserted into joints to simulate arthritis. They might also inject talcum powder to saliva to induce bruising. Additionally, there are medications that can cause vomiting, anticoagulation, bowel movements, Parkinsonian tremors, or low blood sugar. Certain breathing techniques can induce hypertension or low blood oxygen, and they can tamper with urine or blood samples. Most simply, self-inflicted bloodletting, lesions, cuts, or chemical burns have also been observed.
Wow, this disorder seems pretty severe. I hope there are ways to predict its presence.
You're on fire. I was just about to explain that. Recognizing red flags is crucial. These include comorbid disorders, especially personality disorders, as well as depression, anorexia, anxiety, and PTSD. Factitious disorder is more common among young females, ranging from late adolescence to mid-40s. But severe cases of Munchausen are more common among men. These patients often have a history in the medical profession or some related education, so they're familiar with medical terminology. Substance use disorder are also common among those with factitious disorder. Inconsistent or contradictory test results, refusal of psychiatric referrals, or a history of traumatic illness in childhood or with a close relative, and low social support are also common indicators.
How might this disorder progress over time?
Essentially, those with factitious disorders and factitious disorder imposed on another prioritize their psychological needs over their health, often resorting to increasingly dangerous deceptions to maintain the sick role. A significant challenge in understanding this disorder is its rarity, which makes its study difficult.
Why is this disorder so rare?
Well, the exact prevalence of factitious disorder and related disorders such as Munchausen, malingering, isn't well known because diagnosing these disorders is extremely difficult for several reasons.
Hey, why don't I take over for a bit?
What do you mean? You're not as knowledgeable as me. I'm the narrator after all.
Just because I'm young doesn't mean that I'm not crafty. I know a lot about factitious disorder. I didn't want you to feel nervous presenting. As I was saying, factitious disorder is a complex diagnosis because it requires a dedicated, well-connected, multidisciplinary care team with access to the patient's medical records for various institutions. It's likely that factitious disorder is present. The patient is using an alias, fabricated medical history, and a recycled set of symptoms. The care team should work together to identify red flags, as I mentioned earlier. Supportive confrontation should be effective when a necessary level of suspicion is aroused. This approach involves creating a partnership between the patient and the care team, with the goal of working together toward health and recovery. It's important to show sympathetic concern, be prepared for the patient to react ambivalently or aggressively, as the contradictory nature of factitious disorder can cause them to refuse or refute the diagnosis and continue their deception, or even discharge themselves from the hospital. Often, patients with factitious disorder express a desire to get better, but the disorder prevents a normal patient-care relationship from forming. The care team should have a unified treatment plan to avoid confusion in diagnosing or overlooking factitious disorder. That's enough. Thank you. That's enough. I can take over from here. Factitious disorder is often first recognized in a medical setting, where medical staff may try to maintain the Hippocratic Oath by searching for a diagnosis, although this is admirable. When suspicions arise, continuing lengthy testing may be unnecessary and actually fuel the patient's harm. Confrontation about this diagnosis may be complicated. Many medical professions may choose a non-confrontational approach to avoid stigmatizing the patient, but this often delays the diagnosis. And the treatment plan lasts more than 3 years, right?
Yes, that's correct. That's correct.
And occlusive bandages and the avoidance of self-harm and self-bloodletting tools, as well as medications used to induce symptoms, should be withheld from the patient.
Yes, you're right again. You know more than I thought. But please, you're stealing my thunder. Treatment for comorbid psychological disorders and real illnesses have shown promising outcomes in reducing factitious disorder symptoms. Although there are no specific medications and psychotherapies for factitious disorder itself, medications for comorbid conditions such as depression, anxiety, bipolar disorders, and especially personality disorders can help. Factitious disorder is chronic, and the goal is management and minimizing harm to the patient. Helping the patient improve their social support system, addressing childhood trauma, resolving dysfunctional family relationships can also be beneficial. In cases of factitious disorder imposed on others, Child Protective Services is involved in separating the caregiver who induces the symptoms from affected individuals. Both individuals undergo separate psychotherapy. For the caregiver, it's important to acknowledge their behavior and empathize with the person they've harmed. The person receiving the induced symptoms are educated on factitious disorder behaviors to prevent further perpetuation. What's most important in all of these cases of factitious disorder is the patient feels autonomous, respected, and cared for in a healthy manner, distinct from the sick role they previously sought.
I would also like to mention that the patient confidentiality and privacy are important, but there's some debate over exceptions, like filming. Hey, could you help me out here? As I was saying, filming in hospital rooms, creating a more connected database of medical records between hospitals. If any breaches in confidentiality are planned to benefit the patient, they should be discussed among the care team and approved by the patient. Although this can be complicated, many urge that the exceptions should be made when the alternative is undiagnosed factitious disorder leading to higher morbidity.
Well said. Do you see now why this disorder is so underreported, mistreated, and misunderstood? Factitious disorder exists in a space between multiple disciplines, each with its own concerns for the patient's recovery, which sometimes conflict. It's a contradictory disorder compared to the prognosis of a normal patient.
Wow! You did a great job.
Hey, thanks. I tried. Same to you, buddy.